Hi, I am Dr. Mehboob, MD, Ophthalmology from AIIMS, New Delhi. And today I am going to discuss a series of Neet PG rapid revision. And this is very important. Let me tell you why it is very important. This is important because I have covered the whole ophthalmology in a bunch of 100 MCQ. Believe me, this 100 MCQ is very important. If you do that, I bet you more than 60 to 70% of the question you will be able to get in your Neet PG examination. I know the time is very crucial. That's why I have divided this in the 4 parts and of 30 to 35 minutes each part. And you just go and revise, because part 1 is containing the 25 question, second 25 question in the part 2, third 25 question is part 3, and the fourth 25 question is in the part 4. But if you still don't have so much of the time to spend on this ophthalmology and you want to go for a particular topic like cornea, like conjunctiva, retina, neuro-opthal, glaucoma, orbit, then we have an option for you. I have collectively devised this, that from question number 1 to 27 I have discussed the cornea, conjunctiva and sclera. In retina have been discussed in 28 to 62 number question. Rest of them you can see here the number of the question where I have discussed the separate topics. You can directly jump over to that topics and start your revision. Okay, don't skip the questions, because this very important concepts what I am going to tell you is a very important. Why? Because these are the most common things and frequently asked in the Neet PG examination in the previous 5 or 6 years. Okay, so let's start with the first part of this series. What is this? The safe strategy. The safe strategy is used for, everybody knows, but let me tell you the options: trachoma, diabetic retinopathy, onchocerciasis and glaucoma. What is the answer? The answer is trachoma, right? The answer is trachoma. You know about that safe strategy. What is S? What is S? Let me tell you. What is S? S for surgery, A for antibiotic, F for facial cleanliness, E for environmental hygiene. A, antibiotic. What is the drug of choice? Azithromycin 1 gram single dose. Sorry for the handwriting, but drug of choice is azithromycin 1 gram single dose. And it has been asked in the AIIMS previously. Okay. Now there is one more thing that you need to know. WHO grading. WHO grading is FISTO. F for follicle, I for intense, S for scarring, T for trichiasis, O for opacity. Just remember this FISTO. What is being asked in the examination is about this follicular stage. Follicular stage, you need to remember when you call it a follicular stage. When the number is 5 or more than 5. When the number is 5 or more than 5. When the size is 0.5 mm, more than 0.5 mm, and it is present in the superior tarsal conjunctiva. This is follicular stage. Remember that this has come as an option in the AIIMS examination previously. Okay, so it's very important. Second thing, this line is very important. If somebody asks you what is the investigation of choice for this trachomatis or trachoma, then you have to go for the PCR, nucleic acid amplification test. Now coming to this causative agent, many of the times they have asked the serover of the Chlamydia trachomatis, which is responsible for trachoma. So which serover responsible for the trachoma? A, B, BA and C. This causes serover. The serover D to K causes the genital problems. And this is L1, L2, L3 causing lymphogranuloma venerum. You need to remember, this is the microbiology question also. Now let me tell you what is this. What is this? This is the sago grain appearance. What is this? This is the sago grain appearance. This is the sago grain appearance, which is particularly found in the trachoma. Okay, what is this? These are the Herbert follicles. When on healing, it form a depression which is called the Herbert pit. So Herbert follicle and Herbert pits are the characteristic of trachoma. You can get a question over this. These are the subconjunctival fibrosis or scar. This is on the tarsal plate, upper tarsal plate. This is called, very important question, Art's line. Art's line. This is very important question. Okay. Now this is all about the question number 1. Coming to the question number 2. A 30-year-old male presents with progressive loss of vision. What is the clinical corneal picture? Given is the corneal picture. What is your diagnosis? So this is the corneal picture. Let me show you. This is the corneal picture you can get here. Okay. Now the options are lattice dystrophy, granular dystrophy, macular dystrophy, and CHED. So this is important point to understand. To devise this, you have to see 3 points. Whether the particular opacity is discrete or coalescent. Discrete or coalescent. Here this is, here this opacity, this opacity, these are the discrete opacities, and the distance between them, these are the very clear. You can see here, these are the very clear the spacing is very clear. And the third point that you have to see, the involvement of the limbus. So since here the discrete opacities, the distance or spaces between the different opacities are clear, it is not extending to the limbus. So the answer of this question will be granular dystrophy. Okay. Now let me revise you about all these things. So the first important thing, that we can have a different types of the opacities and dystrophies. So there is the epithelial dystrophy, which is the map dot fingerprint. It is the most common dystrophy overall. It is the most common dystrophy, map dot fingerprint. In the Bowman's dystrophy, which is now obsolete, this terminology of Bowman's dystrophy have been obsolete, but they can ask you a question. So remember the two names, Thiel-Behnke, Behnke, and Rees-Buckler dystrophy. Thiel-Behnke and Rees-Buckler dystrophy, that can be asked in the examination. Now coming to this stromal dystrophy. So 3 stromal dystrophy, that is very important: granular, macular, and lattice. Differentiating point. Remember, I am just going to tell you about only the differentiating point. Autosomal recessive macular dystrophy. Rest of them autosomal dominant. They can ask the question over this. I have shown you the picture of the granular dystrophy in the question, right? So there is a no intervening stroma, clear, right? And it was not extending to the limbus. So this was the question. The answer of the question was granular dystrophy. In the macular dystrophy, they extend to the limbus and the intervening stroma are not so clear, they are hazy. And in the lattice dystrophy, there is a lattice line, reflected lattice lines. Now coming to the second question that can be asked in the examination. In the granular dystrophy, what is deposited? Hyaline material is deposited, and so it is stained by the Mason trichome. Macular dystrophy, there is a deposition of mucopolysaccharide or glycosaminoglycans. M for mucopolysaccharide and glycosaminoglycan are the same, are almost synonymous to each other. So mucopolysaccharide here, and that's why the staining is by the colloidal iron or Alcine blue. Lattice dystrophy, amyloid, and everybody knows that amyloid is stained by Congo red. So Congo red is the answer. Just go by this. And I have already discussed the clear limbus zone, not clear limbus zone. Lattice line is present, means involvement of the limbus. Now let me give you the photo of this. This is the lattice dystrophy. This is the Congo red staining. This is the granular dystrophy. See the distance, discrete opacities, the clear intervening stroma. And this is the Mason trichome. This is the Mason trichome stain. Okay, because of the hyaline. And this is what we call the macular dystrophy. The discrete opacities are there, but the intervening areas are hazy. And this is the colloidal iron staining. So they can ask you or give you this type of the picture. That's why I have made it clear for you. I'm spending a little bit more time on this because later on we have a very little short questions. Okay. Sealed ulcer. Sealed ulcer is present in flictanular conjunctivitis, spring cata, herpetic, or fungal. The answer is spring catarrh, which is also known as VKC, Vernal keratoconjunctivitis. So can you see this? This can be come in examination. This is the sealed ulcer. Okay, this is the horner trantage spots. Because of this, excretions or debris is deposited around the limbus. So this is the horner trantage spot, and this is what we call the pseudogerontoxin. Just paralimbal areas may there is a slight depressions along with the ridges are there. So this is the pseudogerontoxin. So pseudogerontoxin is a part of VKC. Horner trantage spot is a part of VKC. Sealed ulcer is seen in VKC or spring catarrh. This is the question number 3. Coming to the question number 4. So question number 4 is very important one. 1 minute. Question number 4. Giant papillary conjunctivitis is caused by, let me tell you, this has been asked in INICT last year. Okay, so it's very important. Contact lens, ocular prosthesis, protruding corneal sutures, and all of the above. What should be the answer? Anything which is rubbing the upper tarsal conjunctiva can cause the giant papillary conjunctivitis. So do you think all these 3 things is rubbing the upper conjunctiva, upper tarsal conjunctiva? So the answer for this question will be all of the above. The most common cause of the giant papillary conjunctivitis is contact lens. So this can be asked in the examination. Now let's come to the 5th number question. A child of weight 10 kg has a Bitort's spot in both the eyes. Which of the following is the most appropriate schedule of for the child? It is the 2 lakh international unit, 1 lakh international unit, 2 lakh international unit on 0 to 14 days, 1 lakh on 0 to 14 days, 0 to 14, or 2 lakh on 0, 1, 14, or 1 lakh on 0, 1 and 14. So remember, if the weight of the patient has been given only, so the cutoff is 8 kg, and if the weight is 8 kg or more than 8 kg, you have to give 2 lakh international unit orally, and half of this means 1 lakh international unit intramuscularly at 0, 1 or 28 days. But in this question it is written as 14 days. So it is also written right because some of the book has written this regimen also. So you can give the 0, 1 or 14 or 0, 1 or 28 days. Okay. But in this condition, in this situation, the weight is 10 kg. It is more than 8 kg, and it is intramuscular injection. So 1 lakh international unit on day 0, 1 and 14 is the right answer. Right? Coming to, let's see about this 2 or 3 things. If the weight of the more than 8 kg or 8 kg or age is 1 year, you have to give this 2 lakh international oral, half of the IM. If the age is less than equal to 1 year or less than 8 kg, then 1 lakh international oral or 50,000 IM. And this is for the female reproductive age, and this is for X2 stage. And therapeutic dose 0, 1, 28, and some of the book have written 14 days. So 14 days is also right. Another important question that can ask you, Bitort's spot. Bitort's spot is present at which stage? X1b. This can be a question. X1b is the stage where you find the Bitort's spot. Bitort's spots are the triangular in shape. It's a frothy triangular in shape. Okay. Coming to the 6th number questions. Iron deposition close to the head of the pterygium is known as. Very important question. Anyone? So the answer, just click. The answer is Stocker's line, KF ring, Fletcher ring, Ferris line. The answer is Stocker's line. Okay. KF ring is present in chalcosis. Okay. Fletcher ring is present, or chalcosis means Wilson's disease, Wilson's disease more commonly, and also in the chalcosis. Okay, sometime in the chalcosis, but Wilson's disease is more commonly. Fletcher ring is present in the keratoconus, and Ferris line is present in the glaucoma bleb after trabeculectomy. After trap in the glaucoma web, you can find this. Now coming to this point, very important, just remember this 4 to 3 things. Elastotic degenerative changes is this pterygium definition. Pterygium is defined as elastotic degenerative changes in vascularized subepithelial stromal collagen. This is important. This occurs in the hot climates and upon exposure of the ultraviolet rays. Pterygium encroaches to the cornea at which layer? The answer is Bowman's layer. And this is the Fleischer ring. This is the Fleischer ring. Okay, FR. This is the KF ring. This part, this is what we call a Stoker's line. Okay. Now I have written everything here. You can remember by just click the screenshot and remember this: Stoker line, pterygium, Fleischer ring, keratoconus, Ferris line, filtering blade, Hutton-Stahli line associated with the age. Got it? Now moving to the 7th number question. That's very important, na? Moving to the 7th number question. So, which of the most common systemic association of the scleritis? Okay, basically we can say it's the posterior scleritis. Rheumatoid, systemic sclerosis, giant cell arthritis, or arthritis means it's not arthritis, it's arthritis, or Ehlers-Danlos syndrome, right? So the answer is, it's a very important question. Answer is rheumatoid arthritis. Okay, let's come to this. The systemic association of this posterior scleritis, is rheumatoid arthritis, which is the most common association. Rest of them you can remember: Wegener's, relapsing polygon, SLE, IBD, or reactive arthritis, polyarthritis nodosa. One important thing that I must tell you: this ultrasonic photographic, that often they in the exam they will give you this photo and they will give you some of the clinical scenario, and you have to diagnose or you have to give the most systemic association like this. This cannot be one liner. So just see this photo, you will find that here there is a scleral thickening, and this is what we call T sign. This is called T sign, and this T sign is a characteristic of posterior scleritis. वन लाइनर में भी आ सकता है कि टी साइन किसका कैरेक्टरिस्टिक है, तो आंसर आपको मानना है posterior scleritis. Moving to the next question. All are true about the cornea except, it's a very common question, but you have to be careful while solving this question. Majority of the reflection occurs at the ear corneal interface. It's the right option. Power is 43. Obviously you know about the in the schematic diagram. 60 diopter is the overall power, where 43 is by the cornea and 17 by the lens. So you can understand the 60 diopter is the overall corneal overall power of the eye, 43 contributed by the cornea and 17 contributed by the lens. So this statement is also true. Spherical in shape, we will come to that. With the rule, astigmatism is seen because the vertical meridian is steeper than the horizontal meridian. So vertical meridian, this is vertical meridian, this is horizontal meridian. Because of the eyelid pressure, this meridian becomes steep, becomes more curved. Steep means more curved. And since it is naturally occurring, that's why it's with the rule, with the nature, with the rule. So this is the right option. So our answer is this one, spherical in shape. Why I have ruled out this? I just want to show that you can also get to the answer after ruling out the different options just by this method. Okay. If you don't remember the answer, just don't worry, just go by the exclusion method. Okay, this is very important. So coming to this is the typical picture of this. What is this layer? This is called the Duas layer. It's a pre-decimate layer before the decimate membrane. Harminder Dua is a very great researcher in the field of ophthalmology who after whose name Duas layer has been credited. Okay, the endothelial layer contains this sodium potassium ATPase pump, which is responsible for the avascularity. The four causes responsible for the avascularity is first, the parallel arrangement of the collagen, second, avascularity, third, presence of stromal glycosaminoglycans like chondroitin sulfate and keratin sulfate, and the fourth, sodium potassium ATPase pump, which is maintaining the relative dehydration of the cornea. Now, coming to some of the important facts of this, the vertical meridian is 11.5 millimeter, horizontal is 12 millimeter. It is aspheric, means flattened towards periphery. This flattens towards periphery, thicker towards periphery, and it's not thinner, it's thicker towards periphery, and that's why our cornea is aspheric. It's avascular and transport. And what is important to understand, the nerve supply, often asked in the examination, often got mistakenly wrong by the many of the students, okay, many of the aspirants. So the answer is nasociliary nerve, which is the branch of ophthalmic nerve. Without wasting time, coming to the question number 9, which organism can penetrate the intact cornea? You know, this is a very important question. Pseudomonas, Staphylococcus, Gonococcus, or Streptococcus. The answer of this question is, everybody knows that, Gonococcus. But you need to remember this code. Never let healthy cornea invaded. N for Neisseria, L for Listeria, H for Haemophilus, C for Corynebacterium diphtheria. Very simple. No need to discuss anymore. Now coming to this question number 10, which is indicating that a young man aged 45 years, difficulty of vision in the left eye for the past 15 to 20 days. It's an acute disease. So they have a history of the trauma with a cow tail 20 days back. On examination, there is ulcerative lesion of the cornea and soft creamy infiltrate with the margins feathery and stellate lesion. This all indicate towards which diagnosis? It's a very simple, it's a very classical example of fungal keratitis. And what is the agent here, which is fungus? Corynebacterium? No. Physiology? Yes. Acanthamoeba? No. Strepto? No. So the answer of this question is Physiology. And let me give you some of the hint which is very important regarding the fungal ulcer. There will be the typical history of the cow tail trauma or vegetative trauma. Now coming to this, the treatment of the choice of this is 5% natamycin. Okay, and the hypopion, which is very important, is a non-mobile hypopion. In the bacteria, it's a bacteria ulcer may the hypopion will be mobile, but in the fungal ulcer it is non-mobile. Dry looking ulcer, diffuse infiltrate, feathery margin, stellate lesion, which was given in the exam, the question. So this is about the fungal ulcer. Coming to the next question, a 16-year-old girl with severe painful keratitis came to the hospital. Acanthamoeba keratitis is suspected, which is not the risk factor of the same. Diagnosis has been given. What is important? For dirty water exposure, do you think that dirty water exposure is a risk factor for the acanthamoeba? Yes, of course. In a mud water or the water where the buffaloes or the different kind of creatures are being pulled on, so this is absolutely a risk factor. Corneal trauma, do you think? Yes, obviously. Why? Because corneal trauma is a risk factor of all the infections which is present in the environment. So obviously, squamous blepharitis, this is a very common disease. If this would have been the risk factor, then so many of the patients will land up to this Acanthamoeba keratitis, but this is not so. That means it is a quite common disease, it's a very common among the people and does not cause Acanthamoeba keratitis. So this is not a risk factor. Yes, extended wear contact lens is a very important risk factor. So the answer for this question is squamous blepharitis. So let me tell you two things. Most common association of the contact lens is Pseudomonas, and the most specific to contact lens is Acanthamoeba. So which is the most common disease associated with the contact lens? Pseudomonas. But if they ask you most specific, you have to answer this Acanthamoeba. One important thing that I must tell you, that this is very important. It is extremely painful. The sign will not be so much, but the pain is very high. Why? Because of this riddle keratoconjunctivitis. Can you see this? Can you see these areas? These areas are the keratoconjunctivitis, and because of this there is extreme pain. Now can you see this area which I have surrounded is the ring type ulceration. So the ring ulcer is a part of the Acanthamoeba keratitis. The most of the time the question is on the culture media, and you have to answer it non-nutrient agar with the Escherichia coli. That's a very important answer. Now The treatment of choice is PHMB. This is a very important one-liner question. Remember this. Coming to the 12 number question. 12 number question. All are seen in keratoconus except central thinning of the cornea, distortion of the corneal reflex, Munson sign, or hypermetropic refraction. So what happened in the keratoconus? In the keratoconus there is a ectasia. There is a ectasia mainly in the inferior cornea with thinning of the cornea, which is usually in the center but not corroborating to the ectatic part. Means apex of the cornea and the thinning corneal thinnest area is not at the same place. Okay, the ectasia will be at the inferior position and there is a central thinning of the cornea. So the option 1 is right. Distortion of the corneal reflex. Obviously, if the cornea is distorted, the cornea is conical, ectasia, corneal reflexes will be deflected. Munson sign, everybody knows that. When you ask to look the down, there is a V-shaped formation of the lower lid. This is Munson sign. How could you say? If there is a conical ectasia, if there is a ectasia, the length of the axial length is increasing, right? That's why there has to be if there is a shifting, it has to be myopic shift, not hypermetropic. So the answer is hypermetropic refraction. Coming to the few signs, can you see this? This is the Cherlocks oil droplet sign. You can get the question over this. Can you see here? These are the striated formation folds. When you press the cornea, you will find this, and this is called the Vox striatum. When you ask the patient to look down, there is a V-shaped formation of the lower eyelid, Munson sign. This is the Fleischer ring is present. Obviously, Fleischer ring is present at which level? Anyone? Epithelium. There is iron deposition at the epithelium layer. Now what is this? This is the typical cone. See, the typical cone is not at here but here. Okay, but here. And the thinning area is here. Now coming to this sign, when you use the slit lamp and illuminate it by the obliquely, you will find this type of the reflection in the other side. This is called the Rizzuti sign. So remember all this sign is very important. Coming to the 13 number question. Band-shaped keratopathy is because of the deposition of what? Calcium, melanin, iron, amylide. So the answer is, obviously everybody knows, it's a calcium pyrophosphate. So the answer is this one, calcium. Coming to some of the important facts that can be important for the band-shaped keratopathy. In the band-shaped keratopathy, there is a calcium deposition in the Bowman's layer, mainly Bowman's layer, epithelial basement and anterior stroma. But there is no calcium deposition in the descending membrane or endothelium. These are not involved. Descending membrane or endothelium is not involved. It's an age-related process, and every disease which is causing the increase in the calcium, they can lead to the band-shaped keratopathy. Example, the hyperuricemia or chronic renal failure. So this can be a precipitating factor for the band-shaped keratopathy. So this is an example of the band-shaped keratopathy that you can see. Now what is the treatment? You have to use the EDTA, ethyl diamine tetracetic acid. So EDTA is 1.5 to 3% you can use, and chelate the calcium with this EDTA for 30 seconds, 20 to 30 seconds, and then scrape it out. This is the treatment of the band-shaped keratopathy. Coming to the 14th number question. Corneal dystrophies are basically, if you say what is dystrophies? Dystrophy is the abnormal trophies matlab configuration. So what is dystrophy? Corneal dystrophy. When you call it a corneal dystrophy, is it a primary bilateral? It is primary unilateral. It is primary bilateral or systemic disease, primarily unilateral with systemic disease. Remember, the corneal dystrophies are always bilateral and never associated with a systemic disease. It is always bilateral, never associated with systemic disease. So among these options, which you think is the right answer? The right answer is, it's a primary bilateral only, not systemic. Systemic disease से associate नहीं होते हैं, इसलिए C और D ruled out. We have primary bilateral, primary unilateral. चूंकि ये bilateral होते हैं, that's why the answer is A only. Now I will tell you some of the important fact. The definition is having the bilaterality, no systemic association, hereditary basis, and it's quite slowly progressive. but these are the some of the exceptions. You have, if you want to remember, you can remember, but I don't think this is very important. Just remember, this is bilateral, not associated with the systemic disease, have a hereditary basis, and slowly progressive. And this is the IC3D classification. I have purposefully put it here for you guys to remember all these things. Okay, it has to be genetic, clinical, pathological, and representative clinical pictures here. So remember, take the screenshot and just revise it. That can be important. Okay, now coming to the 15th number question: which universal marker is for limbal stem cells? Collagen, elastin 2, ABCG2, keratin. This is a sure shot one-liner question. Answer is, anyone just put it into mind, ABCG2. This is the universal marker. Have been asked in the examination so many of the time. Okay. All are sign of the graft rejections. When you do the graft, when you do the corneal grafting, when you do the penetrating keratoplasty, you will get acquired with this type of the failure rejection type. Matlab, failure and rejection will happen. So how do we identify that the graft that we have put is failed or rejected? There are certain signs. Okay. So these are the signs of the graft rejections, but they have asked which is not the sign. Kretschmer spots, Foster spots, epithelial rejection line, Khoda-Dost line. So the answer is Foster spots. Why? Because this is a sign in myopia. This is found in myopic patient, not in the graft rejection patient. So the answer is this one. Let me tell you that Kretschmer spot is present in epithelium. Khoda-Dost line is present in endothelium. Now how will you remember this? D for Khoda-Dost, there is a D in the Khoda-Dost, and there is a D here. There is a D here also. So remember Khoda-Dost in the endothelium. This has been asked multiple times in the previous Neet PG, so remember, important for you guys. Now coming to the question number 17, a patient presents with history of the tuna particles falling in the eye. There is a chemical injury. Tuna particle falls in the eye. What should not be done? What should not be done? Usually they ask what should be done, but here they have asked what should not be done. It's an emergency. Tuna particle is an alkali. Alkali is a very quite toxic, but compared to acids, the alkali is very dangerous. Why? Because alkali causes the penetrating injury and penetrates more to the cornea. But in the acid, there is the formation of scar, E-S-C-H-A-R, scar, which prevents the further penetration. So alkali injury is more dangerous than the acid injury. Now coming to the options, frequent installation of sodium citrate drops. This is very important. You have to start this frequently. So this is the right option. Repeated irrigation of the conjunctiva sac with a normal line. Option number B is very right. Why? Kabhi bhi, whenever you get an injury of the chemical, you just do the thorough washing of the eye. That's very important. Thorough washing. So this is also right. Thorough slit lamp examination. What you will get after thorough slit lamp examination? This will only kill your time, because time is money in this stage. So thorough slit lamp examination can be done even after the initial management have been done. So this is not the true thing. So you have to mark it answer. Okay. And double eversion of the lid is very important, because sometime in the lid the particles get stuck and they can cause the further injury later on. Okay. So dangerous is what? Alkali is more than acid. Why? Because acid forms the scar, further penetration is prevented. Question number 18, a child with a history of the Lyme injury, obviously this is also a chemical injury, back present to the OPD, the clinical photograph here, you can see this clinical photograph, this one. What is this? Ectropion, entropion, symbloferon and blepharophimosis. Obviously this is symbloferon. Remember, this is called symbloferon. Ectropion means there is a turning of the eyelid outward, entropion turning of the eyelid inward, blepharophimosis there is a means the intercanthal distance, this canthal distance, medial to lateral is decreasing, right? Coming to the 19 number question. A patient presents with a complaint of irritation and the photophobia in the right eye. Which is the diagnosis from the clinical photograph? This is the clinical photograph. What is the diagnosis? This is the fluorescent stained photograph. Okay. So can you see what is the diagnosis? Bacterial keratitis, viral keratitis, fungal, or acanthamoeba? Obviously, this is a typical dendrite. This is typical dendrite. So this is dendrites. So answer is viral keratitis. Remember one thing, that steroid contraindicated in epithelium involvement. If epithelium is involved in the viral keratitis, steroid is contraindicated because it can lead to geographical ulcer. Okay. Coming to this 20 number question, ascorbate and alpha tocopherol are maintained in the lens in the reduced state. Glycoprotein, glutathione, glucose, or fatty acids. What is the answer? The answer is glutathione. So this maintains the reduced state of these proteins. Now coming to this, all are seen in the phacodermosis. Phacodermosis सब में मिलते हैं, किस में नहीं मिलता है? Hypermature cataract, pseudo exfoliation, trauma, and diabetes mellitus. Why does phacodermosis occur? Phacodermosis occur when there is a jonular weakness. And now let's see in which stage you will find there is a no jonular weakness. In hypermature cataract, because of the hardness of the lens, the jonules can become weak. Pseudo exfoliation, there is an inherent property of jonular weakness. Trauma can cause the weakness of the jonules. So these three are the right thing. They can cause the phacodermosis, but diabetes mellitus has nothing to do with the jonular weakness. So our answer is diabetes mellitus. Phacodermosis is because of jonular weakness, right? Typical appearance of the diabetic cataract is, any answer? Sunflower, breadcrumb, polychromatic luster, or snowflake cataract. The answer is snowflake cataract, right? You need to know the different metabolic products. Now coming to this, in the diabetes mellitus, as we know that this is the snowflake. This is snowflake cataract. In the galactosemia, what is this? Oil droplet cataract, and this is reversible in early stage. This is also a question. Wilson disease, what should be the answer? Anyone? Sunflower cataract. Myotonic dystrophy, very important. Christmas tree. Lewis disease. Posterior lenticonus. Trauma. Rosette shaped cataract. In the Lewis disease, there is also a spoke-like pattern. Okay. So this is the important, which is very important for the. I have just written the very important thing. You need to remember this. Which is the essential parameter of the IOL for power formula calculation? Keratometry, corneal thickness. These are the options. So let me tell you. What is the formula called? The formula is SRK formula. The formula says that A minus 0.9. Minus 0.9 into K for keratometry, minus 2.5 into axial length. So do you think A is the constant? K is keratometry and axial length. So the IOL power depends upon this K and axial length. So it depends upon the K and the axial length. So the option B is the right answer. Right? Now you need to remember 2 to 3 things that they can ask you in the exam. 1. If the size is less than 22 millimeter, if the axial length is less than 22 millimeter, which formula you should use? Hofer Q. If the size of the axial length is more than 20 millimeter, which formula you should use? SRKT formula. Okay. If in the LASIK patient, if the LASIK patient is there, which formula you should use? Haig's L. So 22 से कम है हॉफर क्यूब, 25 से ज़्यादा है सार्केटी फॉर्मूला, लेसिक पेशेंट में एक ही सेल. दिस वेरी इंपॉर्टेंट, यू नीड टू रिमेंबर. 24 number question. A 5-year man, old man, underwent a cataract surgery. After 3 days, there is a pain and decrease in the vision after an initial improvement, the most probable diagnosis. So if there is a very short period when there is a decrease of the vision just after the cataract, that means it's an emergency. There has to be some infection. Endophthalmitis is suited over there. Central retinal vein occlusion is a slow progressive disease. After cataract, it occurs after 1 year retinal detachment, around 3 to 6 months. So the answer for this question is endophthalmitis. Let me tell you, most common cause of acute onset ophthalmitis is Staphylococcus staph epidermidis. Okay, it is staph epidermidis. Most common cause of the late onset endophthalmitis is fungus and Propionibacterium acne. P acne, Propionibacterium acne, fungus and acne. After cataract में आपको दो चीज याद रखने हैं. Lustreless cataract, polychromatic luster, and this is also known as the PCO, where you will see Ilsching pearl. You will see the Ilsching pearl, and you will also have the Soimer's ring. Okay. Now the last question of this session is, which of the following is the treatment of the posterior capsular ossification, PCO? The answer is ND-YAG laser, and the frequency of this 532 micrometer. So I hope you like this video. Okay, just go through the other videos also for the more interesting, most common, and that's very important for the NEET PG revision. So do your NEET PG revision fast. Thank you very much.